look at a couple actual things that you learn in cases. This is a 44-year-old diabetic with renal failure, renal transplant, non-healing ulcers. So when you see this area, you know, as you get comfortable with these cases, this is hopefully not going to be bad, and it wasn't. The wire went pretty easily. For here, I would start with an 035 system, up and over access with a 6 French by 70 sheath. I'll have the sheath right above this area, and I'll probe this area with a soft tip wire, either an Amplatz, a Benson, in the 038, 035 system with a Bernstein or 104 French glide catheter. And then once I get distal, always inject to confirm you're in the actual lumen, and then you proceed. Now, what size balloon do you use? Either you can use IVUS to truly size it, or for me, if it's a adult male, I'll start usually with a 6 in the SFA pop, sometimes 7, sometimes up to 8 in the proximal SFA. But in females, I'll start with in the 5-6 range and see what I'm thinking. As you get more comfortable, you kind of have your own algorithm. You look for the wastes. For me, I use a lot of scoring balloons, which we can talk about in a second. And then you do your ballooning and you get a result, and then you're going to go into your decision tree. Am I satisfied here? Do I need adjunctive intervention? Do I need a scaffold? Do I need something else? In terms of dissections, this is a picture to tell you that no matter how little you balloon angioplasty, you cause damage, whether it be a flap, whether it be just tiny cracks, you are causing trauma to the wall, which is why those areas of trauma that you ballooned, that's where the hyperplasia comes back and it causes the recurrence and problems and occlusions. So anytime you touch that vessel, just remember you're causing trauma. That starts that cascade. So you try to limit any interaction of a balloon into any area that's normal vessel. Only treat the bad areas. Now, one thing in the SFA you need to consider, and I'm not sure if if you guys have paid attention to this yet, but this is your SFA and popliteal artery as your foot is straight. When you think about the artery being flexed and putting stents, you think that across the knee joint, right behind the knee, right here would be the worst place. But in fact, it's actually in that Hunter's canal, in that distal SFA to the pop. You can see how it undulates. This is an angiogram of a patient with the leg flexed, and you're seeing that the knee joint's right here, but that actual severe flexion is happening over here above the actual femoral tibial joint. So it's important to remember that when you're going through that Hunter's canal and you're treating that area right in that proximal popliteal, that's where the most amount of flexion happens. That's where badly placed stents tend to crack, fracture, separate the most. So that's where you want to pay the most attention to your scaffolding and your choices of stents and whatever you're going to do. Most patients, when you do a claudication case, you're going to find disease right in that Hunter's canal because that's where the most of the motion is. And that's why it's important to understand that concept. And you'll see this on this oblique view with this is a superior stent. You can see that you're getting into this area where there's a bend. That's exactly where that flexion is. This patient was slightly flexed, and you can see the stent kind of holding its pattern, but that's where you need to consider the most amount of flexion.